bringing this all together and getting us here. It's rare when you have friends that are very talented that you can spend time with and that you're comfortable enough with to say, let's open it up, take advantage of everybody's here, and really make this fun. And that's what we're going to do tonight. The format we're going to have is we're going to have very, very short sharing of insight and then throw it open to you and the other members and talk about what we're going to be doing. I'm going to do a short introduction of folks and let them tell you more about themselves than you. I remember being in a meeting recently and someone introduced me as something I'd done 25 years before that I forgot I even did. So rather than me guessing, we're going to do this. Right. Everybody come up and join me. That's you too, John. So three of us have just left a few days in D.C. where we were meeting with the Surgeon General of the Army and people with special forces and other folks to try to come up with different ways of solving some of the problems that we have dealing with health and healthcare. And one of those mechanisms is a big shift that's going on with the feds to focus less on sickness only, but also things that we can do to promote health. And as I've talked with many of you here, which represent such an eclectic group, it's very exciting to be with you. There's so many different ways that so many of you are bringing different things to the table. What we're going to try to do is to share some of what we've been doing and some of the insights we have to see if there's more synergy to make your life even better. I've been working with a think tank in Washington that is across the military health system and working it around other sectors of government to shift the trajectory from healthcare to health focus and from patient to person. We'll be talking about that person because we're very concerned in this country that we spend so much on healthcare and people don't seem to be responsible for changing things. And many of the problems that people have that make them sick are lifestyle-related diseases. But at the same time, there are patients. And what are patients? There are people that are passive, people that are victims, people that are on unequal footing, people that are sick, and people that are vulnerable. And yet we're upset when they don't change. If we want them to change, we feel rather than having them have skin in the game, let's throw the whole person in the game. And that'll make a big difference and let people drive, not being concerned by being accountable, but self-determining their life and their trajectory. In terms of addressing some of that and what various components we have, I'm going to now introduce other folks. Clint has been, as you know, a leader in mobile and digital health solutions to try to give people tools where they can either know what they need to know about themselves, so as a person they can make more astute choices, or to give them the ability to have access to information in real time in a continuous and dynamic way, rather than those 2 visits a year that we go ahead and interact with our physicians. He's going to tell you more about himself as well, and then I'll introduce each person individually. Clint?
Thanks, Dennis. It's good to be back at the ComNexus events. It's been a while since we've been together. But my name is Clint McClellan. I'm at Qualcomm Life, and I'm also the president and chairman of something called the Continua Health Alliance. Has anyone ever heard of that? Don't worry if you haven't. Okay, great. It's a standards group, basically, that builds an end-to-end system that allows you to collect biometric data, blood pressure information, send that to a gateway, and transpose that and send it to a health record system. In a nutshell. Well, in that nutshell, it took 200 companies about 6 years to develop the guidelines to pull that together. So that's much of what I've been working on, because many years ago, I started working with the Carlos Slim Health Institute and some other groups. We were taking off-the-shelf phones. We were trying to connect them to sensors. And you'd go swap out the phone, and suddenly they were interoperable because the Bluetooth spec was slightly different. So that's one of the things that Continua solves. But back at that time also, everyone was looking at how much time do you want me to spend, Dennis?
Go ahead.
Okay, sorry. Like chronic care. Everyone was looking at disease management. What do you do with a diabetic? What do you do very, very, not myopically, but like with population health? How do you help people that are already sick? Well, the problem, as we realize with that, as Dennis mentioned, 95% of that illness is caused by environmental and by behavioral issues. So you're trying to, first of all, maybe help someone that's already not complying, but then you're working with a healthcare system that's really an oxymoron. It's a sick care system. They don't know how to keep people healthy. They're there to fix you, button you up, send you back out, and in some cases, the business model doesn't line up. They want to see you back. So you're trying to force a square peg into a round hole here. So what's happened is unbelievable transition has happened over the last year. And it's really started where I met Dennis. We were visiting the military Department of Defense workshop, and they were looking at their triad of health: activity, sleep, and what was it? Activity, sleep, and nutrition. That's it. That's preventive. That's maintenance. And they want to focus the tools there. And a lot of it is because now we do have the tools we can use. So you're seeing this convergence that we see with the quantified self, the Fitbit people who are very compliant. That type of tool is now making its way back into chronic care. And the key is that I don't think any of us want to be sick. None of us want to be fat. None of us want to go to the emergency room. We just don't have the tools. I know more about my car than I know about me. So now the new effort is to build these systems that will correlate. Okay, I'm active. Well, what's happening? I hit my 10,000 steps, but my blood pressure hasn't come down. So we're going to see these dashboards where now I look at sleep. Oh, that's the problem. If I do something with sleep, then maybe I can pull this together. And it has to be our responsibility. And the healthcare system actually is everyone in this room, taking care of your loved ones and others. That's really where the responsibility has to go. But it's a phenomenal transition over the last year.
Clint, share also, before you pass the mic, some of what you've been doing with the United Nations and expanding this beyond here.
Well, a lot of what we did 2 years ago within Continua, it was a tough sell to get hospitals and medical groups to buy into a standard. No one wants to buy into a standard. It means the engineers have to take extra time, there's extra effort, there's certification. So we altered our strategy and said, okay, let's go to the UN and get them to make it a global standard. So there's a group called the ITU, which is the UN's standardization body. So they took Continua. It didn't take very long. We went to Geneva, presented, they liked it, they put it in the work group, and within a year, it became the global standard for connected health. So I started doing a lot of work with them there, and now the WHO, which is the medical arm really of the UN, and the ITU have combined forces to look at health. They're looking at, we were at a workshop with Matt about 2 months ago, and we were at an activity workshop. So the UN basically feels like they put all the protocols together for tuberculosis, for all of the communicable diseases. They now are looking at chronic disease as the next epidemic. So they're putting a lot of effort to put these protocols together to basically educate health ministries. So we have a bunch of work going on with them, and also to help build plans to build these connected systems.
Yeah, thanks, Clint. So John Madison, who is the CMIO of Kaiser and the assistant director of Kaiser SoCal, and also the creator of a concept called the Behavioral Symphony of Wellness, which I wish I would have thought of instead of you, is here. And John will share some insights in terms of connected health, some of the onomics that he's very, very good at, and all kinds of other cool things that John can talk about. John, go for it.
Thanks, Dennis. So it's a privilege to be here. I'm going to keep my comments really short, but I describe myself as a recovering evolutionary biologist and a recovering physician and now a recovering informaticist. And where I've arrived with the notion of a behavioral symphony of wellness is that healthcare is so fundamentally broken that we're not going to fix it from within the healthcare system. What happens in the office and the clinic represents about 0.005% of our lives. And the transference of what occurs in the clinic or the hospital to real life is pretty minimal. And so if we're looking at what really motivates people to live healthy lives in terms of healthy activity, healthy social relationships, and I actually characterize the triad a little differently. The common triad today is exercise, sleep, and diet. If you talk to Dean Ornish, who's really the pioneer in this field, has been working on this for decades, he doesn't mention sleep at all. And the reason he doesn't do that is because if you have healthy social relationships and healthy activity and healthy dietary habits, you sleep well every night. And he has found that to be sort of a universal outcome. So I think that I like to substitute healthy social relationships, and that includes, your family, your friends, your spiritual relationships with others as being very impactful. The only other thing I'll say in the intro, because we want to have time for questions and debate, is to disagree in one sense with the famous Shakespearean saying of a rose is a rose, and how much language does matter. And so one of the things that Dennis is one of the strong advocates of, myself as well, is shifting away from the patient-centric view. And so it's been pronounced that we've solved that problem. Now we have a consumer-centric view, and that's the end of story, and consumers actually buy things. And so I think that falls far short of where we really need to conceive of health and wellness. And so the person-centric view is a much better representation of that. And it may sound like semantic splitting hairs, but in fact, I just read about some research done recently about the impact of language, sort of neuro-linguistic programming side of the world, where in China, when you refer to your uncle, it's like the Eskimos have how many terms for snow. Well, in China, you can tell when someone talks about their uncle about whether they're an uncle by marriage or an uncle by blood, and whether they're on their mother's side or their father's side, and they would never refer to someone as just their uncle. It's much more specific. And that really reflects the depth of their relationship. And any of you that know Yiddish know that mishpucha refers to an extended family. There's really no concept of the extended family outside of your nuclear pedigree in a lot of other cultures. Another observation is that in English there's past, present, and future tense. In Chinese there's really only a present tense. And so studies of that show that one of the major consequences is when there isn't this clear distinction between mañana and today, there's much more of a focus on the future, ironically, without the verb conjugation being relevant. The last thing I'll mention is that in some Aboriginal societies, they don't say they're holding something in their left hand or their right hand. They refer to the northeast hand or the southwest hand, because everything is referenced absolutely to direction, and everything in their life is related to their sense of direction, and they never get lost, and they know their way around. And so if you think of the power of those words in different cultures, and you think of the distinction between patient-centric, consumer-centric, and person-centric, and what I like to conceive of as the symphony, a behavioral symphony for wellness, what we do in healthcare falls far short of what's needed to really revolutionize health and wellness in the country. And much more what we need to do is help provide behavioral cues that sustain healthy social relationships, healthy dietary patterns, healthy exercise patterns. And when it comes to all of the mobile technology, and Clint's heard me give this talk at a TUNET conference, I am much more interested in creating mindfulness, so that, just one question, how many of you have ever worn a pedometer or Fitbit, just ever? Okay, and how many of you have one on tonight? Okay, so maybe 3/4 of the hands went down. So digital nannies are not the answer. I like to think of the wearables and the sensors as being incredibly valuable for initiating, motivating, and calibrating mindfulness, but not being how many steps did I take, but seeing an elevator and saying where's the stairway. And I think that applies to everything we do. So same thing for calorie counters. It's not that hard to eat healthy if you pay attention. And I don't think we need an app to tell us whether or not we should eat a McDonald's hamburger or not. So
And patients aren't mindful.
yes, and
People are mindful.
People are mindful. So thank you. And so I think we need to shift the focus very dramatically, and I think language is very powerful. And I think person-centric view is fundamentally different than either a patient-centric or a consumer-centric view.
So we're going. Matt now is going to follow. Before I talk about Matt, it's kind of interesting because John, 4 of us have been involved with the Surgeon General at one time or another of the Army, and the thing that's interesting is that the Army's position on the performance triad is sleep is the most important thing you can do, because if you don't get enough sleep, you're intoxicated and your performance is going to be way down. So sleep before anything else. Ornish and some other folks, including me, believe that activity is primary, but that's because I don't need to be in harm's way in the same way that soldiers have to be or sailors have to be. So Matt is going to talk about personalized medicine and how it fits in with this, because different people respond in different ways. For example, John says people use the Fitbit to calibrate. I use mine to compete with myself. I love it. And I've talked with Fitbit about this. It happens to be something that I have fun with. And I do count the steps, and if I get them, great. If I don't, whatever. But I use it as a tool. So different people will use things in different ways. Matt comes from farther than we do. I come from Imperial Beach. That's kind of far. But Matt comes from Brisbane, which is farther. And he is going to, he's involved with a company called the Ultimate Human Foundation. We do some work together there as well. And he has some very, very interesting kinds of solutions of how we change the way people live their lives, what they should be eating, how should they be spending their time and some of the research that they're doing. Matt, it's yours.
Thanks, Dennis. And yeah, I guess just to give a bit of a background, the Ultimate Human Foundation is a non-profit that represents an international collaboration of a lot of leading doctors and scientists, specialists, health ambassadors, researchers. And we're really trying to answer some pretty big questions out there. Particularly the mission is to eliminate chronic disease from the planet by the year 2050. So we're working on a 40-year plan at the moment, which is quite big. And yeah, I guess some lots of interesting insights into that so far. We've spent a lot of time working in the fields of genomics, a lot of different areas that we look at, such as sleep and activity and nutrition, as everyone talks about. And we're really working now in the fields of the phenotype, which is more to the expression of your genes, as opposed to the genotype, which is more your predisposition to something occurring for you down the track. So we particularly look at a lot of different fields of those at the moment, and we're looking to quantify certain measures in the fields of exercise and in food, in the brain, in areas such as sleep, social interactions, the community, careers, and particularly the environment, both outdoors and indoors, which is where we do spend a lot of time. So we do a lot of interesting research internationally. We're just coming over here at the moment in the US. We've got a study that's starting with Scripps in a couple of months, and through UCLA with some of the neuroscience guys there. That we're really looking at trying to quantify that, and we're doing some pretty cool stuff in the biotech space, using a lot of the upcoming biotech companies and sensors, wearable technology devices, such as some companies you guys might be familiar with, such as Vital Connect. There's a great new smart sock coming out called Sensoria. I'm not sure if anyone's familiar with Sensoria. Show of hands at all. Check it out, it's going to be quite cool. It tracks a lot of the biomechanics and measures a lot of interesting things with your posture and how that affects your body. We work a lot in the neuroscience fields with emotive, if you guys are familiar with emotive at all. We look at a lot of correlating between the brain and the body, and particularly interested in answering a lot of those questions as to how can we identify the different balance in all those different areas and really find a way to quantify what's personalised for every person. The general recommendations of sleep and exercise and nutrition just aren't cutting it, and it really is different for everybody. We all know a lot of different people. Everyone knows the person or the story of the person who lived over 100 who drank and smoked their whole life, and the young lady who was 25 years old or 30 years old who had breast cancer, who was healthy and exercised all the time, ate the right foods. So really trying to answer the question as to how's that different, and trying to quantify what's different for everybody. We work a lot in the predictive medicine and the preventive medicine areas on that, and a lot focused on the epigenetics at the moment. We're really focused on the future and a lot of the biotechnology areas to help match that. So really bringing the healthcare and the technology together to support that. So that's a bit of a summary about what we're up to at the moment, and pretty exciting. Thanks very much.
You're not done yet.
I'm not done yet.
So Matt is the only one on the panel, by the way, who's a former Australian League football player too. Professional football player, should add that as well. Matt, you're doing some interesting things in this area that I think would be fun too for people to hear just a bit more, because you're bringing in other facets to try to find with a comprehensive integrative approach. You might talk about some of what's going on with the embryonic stem cell research and the brain mapping and personality and the like. You know, you want and the clubs, if you would.
Okay, yeah, sure. So we'll, I guess just a thing to consider, we're in the predictive space. We're working on some very, very large projects in what we're trying to achieve. Obviously, our mission is very ambitious at best, and so we believe at the moment with one of our first projects that we're working on, which is very large, the first step of that is predictive medicine, and really to change the perception of health of the population is a very hard task. At the moment, as everyone's talked about, we tend to, when something happens, when we get symptoms, when we're sick, we go to see the doctor and expect to get fixed. We're very much saying that we need to be able to get an insight into our bodies as to the processes that are going on, which then relays symptoms in 5 or 10 or 20 years. We're all very familiar, hopefully by now, that chronic diseases do show up a long time after in terms of the symptoms, and they start a long time before we actually get symptoms or we get sick. And so really try and get a lot of insight into that predictive aspect, and we believe that when we do get that insight, we can really, I guess, take that next step towards people taking note of their health earlier than when they get sick. So we do a lot of work mapping the brain. We do a lot of predictive analytics in terms of people's personalities. We're working a lot on the aspect at the moment of actually people adhering to a certain regime. As John spoke about, you can wear your Fitbit all day long, and does that make any difference? Well, actually to Dennis it does. To John it probably doesn't. And so really trying to answer that question as to what can we consider, how do people's brains work, what's the difference between each person individually, what message is going to resonate with them, because until we can answer that question, throwing out a blanket approach is really going to be hard to hear for a lot of people. And so I guess the I don't know how you summarise it, but it's quite a difficult area, and that's a very large part of what we're doing at the moment is really that following along the lines of what we can actually predict and how people are actually going to respond to those messages individually for them.
But this is something to empower people, all these things in a different way, as persons, to make a difference in their lives, their future, and to be there for their loved ones. I'll pass it on to Daniel, if you would. Daniel, I'm going to have them tell you more about yourself. Daniel is the head of the health exchange here in this area, and is really it's a Beacon grant, one of the most innovative of the exchanges I'm aware of in the country. And we met because we are very concerned about some of the failure to share information that we all need to know about ourselves. I had just come back from at Singularity University, hearing about, with some Google folks and such, hearing about all the things that people know about all of us, and had read John's work on depersonalized data and how in today's digital age it doesn't mean a whole lot, and how we really need to think about being honest with people about transparency, what we know and what we don't know, because there's so much that's known about us we never thought anyone would know. So we wanted to look at HIPAA in a different way and maybe rethink how we do population health. Daniel's going to share primarily what infrastructure is needed to make a difference, and tell them more about yourself, Daniel.
Thanks, Dennis. Dan Chavez, Executive Director, San Diego Health Connect. We are the independent, not-for-profit utility that's been established here in San Diego County to connect all of our healthcare providers over a common, secure, and private network. Our sole mission is providing access and integration of data, these disparate data silos that are the hospitals, that are the physicians, that are the health plans, the pharmacies, the laboratories, the imaging centers, over a common network that is shared and secured. So we're bringing together all hospitals, all physicians, all clinics, all health plans in San Diego County over this common network. And a lot like my previous panelists, we're trying to connect those other things, the new applications, the new devices, over this common network in San Diego County, and ensuring that they're adopted and utilized by the caregivers, by the physicians, by the nurses, by the physician's assistants, having that information readily available and accessible by those that provide care, whether that care be in the home or in the institution. Working very hard to make this happen, not only with tremendous technology, it's got to be tremendously simple, a lot of governance issues, a lot of policy issues, and we're working through those as we speak in a very, very collaborative manner, funded by the institutions that provide care in our great county, including the County of San Diego, including the City of San Diego. So doing this all over a common platform in a consortia collaborative manner. Very exciting stuff, about a 3-year project. Hopefully have all hospitals, all physicians accessing data, your data, if you consent to it, via our network. And I thought, I don't know, it was Brittany or Rory, but I thought the logo on the invite was phenomenal. Patient-centered in a circle of physicians. Just reinforcing the requirement for a healthcare information exchange. Just a great logo. We really like that. I'll be using that in some of my presentations.
Okay, so as you can see, we all think the same. Any comments among the panelists before we throw it open to the group, or no? Anything, Bernie?
I just want to make two distinctions. One is the military's focus on sleep because they'll frequently deprive their people in combat of sleep, and so I think for them to give people 8 hours to sleep is a good thing. But there are other things that are more important in a non-life-threatening situation. The second thing is I wasn't discounting the virtue of Fitbit or any of the wearables. What I'm saying is the intent can be the number of steps you take or the way you think about activity in life. So it's not that the Fitbit doesn't work for me. It's that I like using the technology to initiate, calibrate, motivate, and calibrate, as opposed to become my digital nanny. So it's a distinction.
So I don't want to let you off the hook yet. So my sense is what you're saying, and I think you're dead on right, is that these technologies initially can become a springboard for changing our lives, integrating our lifestyle, and really sustaining a behavioral change that sets the tone for the future. So
Well, it's funny you should use the word springboard, because B.J. Fogg, the Stanford founder of Persuasive Technologies, the term, the book, the program he has, uses that term regularly as springboards.
he took it from me.
So, yeah, I think the technology can play a very positive role, but I also think that there's 3 different levels of monitoring, and the first is the athlete aware, where you need intensive awareness of every physiological parameter on a moment-to-moment basis. The second are those that are chronically ill or at risk of being ill, where you need intensive monitoring to help anticipate early and predictive analytics to prevent adverse events from happening and catching them early on. And the third is the rest of us, and that's where the mindfulness piece becomes more prominent than the digital nanny.
I was just going to say that after the workshop we went to where the military was talking about sleep, I'm a big advocate of sleep. And Dennis and I argued about this only because obviously if you have good lifestyle, then sleep comes naturally, but most people don't know that poor sleep causes and accelerates diabetes and hypertension and weight gain. So from my perspective, it's almost an educational component. This has been getting more and more attention over the last 2 years. But how can you manage that and monitor that and just understand that when you don't get good sleep, it's a detriment to your health?
Yeah, we're finding some interesting research as well on, I guess, the balance and trying to quantify between the exercise, the nutrition, and all those other aspects. And there's a lot of people out there that will get some really big gains in specific areas, other people that need balance in all those areas. And so I guess, it's certainly in terms of the tracking and the wearable technologies that are out there is going to offer a lot of value in different ways to different people. There's some people that have serious diseases, chronic diseases, that can have that completely turned around and have their symptoms completely cured, if you like, from foods alone. Other people from exercise, other people from changing their mindfulness or mindset, other people that need a good balance of all those things to be able to achieve that. So it really is interesting at the moment with the research just to show how much of each of those areas can influence either the expression of genes or the person's life, and how we go about that.
So one of the other elements that becomes very exciting when you start looking at a person-centric approach, even the way in which we look at prevention, changes rather dramatically. So in a sickness model or a disease model, we speak of primary, secondary, and tertiary prevention of illness or disease. In a person-centric approach, we speak of readiness, resilience, endurance, and perhaps even hardiness. So we want to be able to do the things we need to do them long enough to do them well, not to get beat up when they don't go quite the way that it's a whole different way of thinking. And anyway, yes, Daniel.
And I will react to that, because what we're doing at San Diego Health Connect is preparing a separate cloud for that person-centric approach, separate and apart in a secure manner from where your electronic health records reside today. So we're preparing for the devices and the integration and a lot of the a la carte person-centric applications. So we can collect that in a secure manner and integrate it with the mainstream healthcare, electronic healthcare records.
Well, why is that important? Who cares?
Well, ideally, the person cares. But we want to be able to consolidate and aggregate that information so that it has a presentation that's usable by the physician and is adopted and utilized by a physician.
So Daniel, what if I were a physician and I could get information from Fitbit and Runkeeper or Pulse? Doesn't have to be a Fitbit, but these devices that give me information and other kinds of things in a continuous, dynamic way, and have that go to my electronic health record. Might that make a difference rather than reported outcomes that people give us about how much they exercise?
It might, but the flip side is maybe information overload. And is a physician going to monitor real time that level of activity of one patient? I mean, we can ask John that question and what his thoughts, or Matt.
Go ahead.
So when I think about this challenge that you're talking about, I always think about Joe and Mary who work at the post office in the Deep South. They could give a crap about all the stuff that we're talking about and frankly don't even know what a Fitbit is. So how do you get it? I'd love some thoughts on how you get a trickle down to the real consumer
John, can I start? And then go from there. So this, we've been working on a White House monograph on this person-centric position. And some of the criticism that we got early in the game is, oh, okay, so that's great. You're affluent and you have the ability to do these kinds of things and you're blah, 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 blah. But how about for, people that have to decide whether to get hamburger meat or gas for their car and so on and so forth, and they're not even in the zone to begin thinking about that. And how do you not take this discussion about accountability and have the Tea Parties take it and run away with it? Real concern we have someone who was working at RAND who does a lot of social justice stuff, and they're very sensitive to that, and I took it to heart. So I don't talk about accountability when I talk about person-centric positions. I talk about self-determination. Each of us has different ways, different choices, different preferences, different ways in which we express our values and what's important to us. So I would much rather use the language of self-determination and have responsibility that emanates from that than I would for something of accountability, because small changes make huge differences. Maybe I can make an 80% difference, someone else can make it 2, but that 2% is a big deal. So to make it, right now the way in which we deal with health, it's daunting, it's almost impossible. You want to buy healthy foods, they're very expensive. You want to get into a good weight loss program or a food addiction program, you better have some money. So it becomes very difficult. So how do you have some kind of parity for people that are disadvantaged in society? So the answer, and John will probably answer this better than I will, and he and I have been working on something dealing with community that he can do a better job of than I will. You need to have some kind of supportive infrastructure to allow people to be successful and to be encouraged by the fact that those small changes can make huge differences. Yes, John?
So I think it's a great question, and I think it's the most relevant question, because if you look at the population of kids in one of the top private schools in San Diego, you see very little obesity. And you go to the public schools in the inner city and you see nothing but obesity. So I think your question, Malcolm, is really critical. So how do you reach people? How do you reach the majority of people that account for the 40% epidemic of obesity and all the consequent downstream effects? It's not just diabetes, it's cancer, heart disease, stroke, dementia, Alzheimer's. Those are all very directly and scientifically related to obesity. So how do you reach Joe and Mary in the post office in the South? First thing is, I think we need to change the medical model. The medical model in a big way. Medical education needs to be transformed. Instead of selecting really the smartest people who are very good at test taking, that we need to have much more focus on empathy. Because the first thing you do is you need to ask Joe and Mary, what is it what is it I can do for you? What matters to you? Is it the fact that your daughter's a crack addict? Is it because your marriage is in the tanks? What matters to you? And until you can address those kind of issues, they're not going to be able to hear diet and exercise and sleep. And you need to deal with them up front. And so I think empathy as a prerequisite for selection and training of at least primary care physicians is the first thing. The second thing is I'm doing a lot of work with the social determinants of health. And if you look at the social determinants of health, there's a lot of good science about what matters and what doesn't. How far away is the nearest store where you can actually buy real food, as opposed to the inner city where all you get is highly processed, high fructose corn syrup and other stuff that's really bad in fast food.
Food deserts.
Food deserts, yes. And if you haven't seen the Institute of Medicine HBO series called Weight of the Nation, it's online. It's the first time HBO has ever put anything online for free. It's a 4-hour series on the Weight of the Nation. It talks about these social determinants. So I'm working with Barbara Wood Johnson Foundation, Institute for Alternative Futures, and the Public Health Informatics Institute to establish the equivalent of a health quality or disease quality set of metrics, if you will, which is what HEDIS and the National Council of Quality Assurance does to benchmark health institutions, to create a common set of metrics for communities. And one of the big findings in all the public health literature is that the single best and overwhelming predictor of the health of a community is the median income. And so are we going to go raise the median income of communities in 40 years? No. But we need not to use that as a cop-out for all the other things that can be done. So you can go to a community with low income and you can provide safe sidewalks, you can provide safe parks, you can deal with the percent of blighted space, you can deal with a median distance to various social services, you can deal with a median distance to parks where kids can readily get some healthy activity for free without being sold drugs. And so I think a lot of social policy historically has failed to recognize the extent of the opportunity that extends beyond the median income of a community and deal with some of these issues. And the Public Health Informatics Institute and these other organizations are really working on it. Just one last thing is that having the ability to benchmark communities against each other becomes really important. And I just spoke at a conference of local community leaders, city councilmen, mayors, county supervisors from all across the state of California. And there is a growing awareness that there's a lot that they can do to make bikeable communities, to have walking distance to basic services. And so there is a huge revolution happening in resilient communities and sustainable communities. And to answer your question, I don't think we're going to get to Joe and Mary on diet, exercise, and sleep. We need to first understand what are the primary issues, and then we need to make it easier for them in their community to do what is healthy.
I'd like to build on that and then have Dan and Clint follow. So I got involved early in the year with the Clinton Foundation and the Health Matters, and they're talking about various things that John's talking about, as well as lighting, reducing teenage pregnancy, and the like. After Bill Clinton spoke, the next person to speak was a 13-year-old boy from Fort Lauderdale, and he got up and he said, you know, I'm the first generation in this country that will likely not live as long as their parents, and went from there, and it was really profound. The thing that's missing, and I think John captured it beautifully, is that we see a tension between the person and the system. Sometimes they support one another, sometimes they don't. But we have been miserable in terms of integrating the community. That's what Daniel is trying to do. And maybe you can respond, and then Clint, I'd like you to respond.
Yeah, sometimes we get too caught up in the technology, what we're trying to do from a network perspective. There really is the human element in the public outreach and the understanding and the education, even at a network level. And what we're doing at San Diego Health Connect is including all these various components, including the County of San Diego, fire, police, taking the social services that are provided in San Diego. They're all going to be part of San Diego Health Connect. So we can talk a lot about the technology, talk about standards, talk about data access and integration, but it's the public outreach. Dennis and I are working on a public outreach piece to explain patient consent. How many people in this room, with the proper levels of assurances that they're going to have, that San Diego Health Connect is a private and secure network, are willing to consent their patient records? But not everybody. And how do you get Joe and Mary to understand patient consent? So that's half the battle, is this public outreach. And to do this in a timely manner, in this 3-year project time frame, where I have all the vast majority of San Diego's populace records accessible to our caregiving community. It's a tremendous education piece that's a little different than sleep and diet and activity, right? That transcends the mainstream healthcare system. And we can use words like HIPAA and Kennedy Castlebaum 1996 and the like, but I've got to get Joe and Mary to say yes. I understand what's being done here.
Give them a reason to say yes.
Give them absolutely. So key to our success in standing up this network in San Diego County.
I was just going to say that your point is great, especially the Fitbit, the out-of-pocket market, or the cell phone that'll connect with it. What does it look like? This came up at the workshop with the UN. We began to think, if we really look globally and we're looking for lowest common denominator protocol, it doesn't include devices. So we began to think, okay, at one end of the case is you have a single mother of 5 in Mexico City, and there's no place safe to walk, and she can't go outside. So what does activity look like? And it doesn't necessarily need the device. We had someone come in and actually ran us through an activity that we didn't move. So the idea, we stood still and we were doing these windmills for like 15 minutes. And so that then struck us all. It's blood flow that matters. That's what activity does if you're outside and walking. So how can you, in a stationary environment, build these protocols? So the WHO, what they will do is develop these and give them to health ministries, who will then bleed those through different hospitals. So in a lot of cases, internationally, this is going to happen a lot faster. My favorite example, 4 years ago, when we were with the Carlos Slim Health Institute, We went to meet some diabetics who were monitoring their health, and they had improved, their blood pressure was under control. So we go to see them, and I thought, wow, I get to see a spot where some people can use these tools, and potentially they have them already. They didn't have any tools. They could afford one strip per week, but what they did was they knew their numbers because the Institute puts together workshops, and every Saturday, clinics, every Saturday the villages come to one spot and they learn about what to do. So they teamed together, and it was like an analog social group. There was nothing digital about this. So they helped each other, and they would learn from each other, and they told us they would rather ask each other for advice than ask a doctor. So in many cases, you're absolutely right, but the key is here in this country, how does the system get there? One thing that is happening is that many systems are beginning to subsidize these devices. And these devices are going to come down in price very quickly. So right now it's a niche, and they're building a market around a service around you. So that's one of the positive things here. But a lot of it, I think, is the willingness to educate populations, and how do we do that?
Go ahead, Matt.
Just quickly on that from our aspect as well, I think there's a question up the back, Dennis, if you want to get your steps up on your Fitbit.
I'll be right up to that first, okay.
So just on Bob and Mary, from where we look at things, we've got a very big perspective on how we look at the world, how we look at health at the moment. And we're very interested in Bob and Mary's children and their children's children. And so we understand that there's a lot of work that needs to be done now to get to Bob and Mary and to help. I think there's over 4,500 chronic diseases that exist in the world today. How are we ever going to prevent those? How are we ever going to get to the bottom of this? So we understand it's going to take quite a lot of time to do things such as John's talking about, changing medical curriculum, changing education from a high school and primary school age, to have people actually grow up knowing what you should do and what's right for you. And until that time comes, which will still be another decade or so, maybe even a couple of generations, we're going to be still fighting like an uphill battle the whole way. So we're certainly trying to answer the questions for the next generation or two generations, because someone has to do that now as well, so that we're successful when they're born. So that's the way that we're looking at things too, from our point of view.
Hi, I'm PJ Palmer. Exploring this world as a career. I have like 100 questions, but I will throw it out with, and Malcolm stole the question that I was actually thinking. I saw Malcolm yesterday. My question is, I'm type 1 diabetic, and I know how exhausting carrying everything around is, and I also know when you have more income and less income in terms of the amount you can test, and you don't have a wireless, and you do have a wireless, and there's an exhaustion that comes with it. And then I also think about my kids. So I'll sort of throw out two topics. One is how do you trickle it down in terms of not having too many things, and people are embarrassed what their numbers are and how much do you really need, and then how does that get into public policy? But the other idea is, there's any gamification of these ideas in terms of making it more fun, in terms of how people get it, because when you say I can have a good blood sugar, it's really hard to know, 82 versus 86 in terms of my HA1Cs. But when you say, I don't feel like I have a hangover when my blood's 280 and I can measure that, it's actually affecting me on my daily basis. So is there a push more towards helping people feel like they're living a better life, they can wear better clothes, they feel less itchy, they're sleeping better in terms of living now versus how long you're going to live, which is, to me, with a long-term disease, is a much tougher sell.
Thank you. Matt, you want
I guess just to answer that question, I'll just give a specific case scenario. We work with a lot of amazing minds internationally, and a case that comes to mind, for example, is a type 1 diabetic who had their pancreas removed, who went and did an assessment to find out all the different areas in their life, where we talked before about the epigenetics, which is really the things that can influence the way your genes are expressed. And for them, we're able to identify a very specific protocol of food, of exercise, social interactions, of career, and they actually normalised and completely got off all medications, and diabetes wasn't present whatsoever, even after they had an operation, which we still, medical science can't explain still. So we're finding a lot of phenomenal areas when we look at the balance that's specifically right for the person, and some things that's really going to challenge the whole paradigm of science and medicine that we think of today. And so that's probably just the first way to answer the question. I'll throw it open to the others for some comments.
we have a question back here. Go ahead.
Do you want to answer that first, or?
No, they'll go back to it. Go ahead.
Okay. My name's Brian Allman. I'm here with Sarah from True Sage. We're delivering around 100,000 health and wellness techniques by video to people. We started out a great call, the senior phone, and there's around probably 30,000 of them getting the calls. And we realized if we get to the kids, that would be much better. So now we're in kindergarten through 8th grade, delivering the calls. And it was challenging getting the schools to pay for the calls. Obviously, they have no budget. They're not even having music classes or PE classes. So what happened was we found a foundation that was willing to support health and wellness calls. And now we're in the Encinitas School District and El Cajon School District. And the kids are getting techniques, go in and teach them a little bit in class, and then support them and their parents and their teachers through very short 1-2 minute videos that basically teach them mental, emotional, behavioral how-tos. The hardest part for us has been finding engagement. Like you mentioned, gamification, finding things that would really get the kids super excited, creating contests, and creating reasons for them to participate. And we're still cracking that one. We're still working on that. It's only been added in the school district for about a year. So once you get that many people using the techniques or getting the calls, it's really sustaining that.
Absolutely.
And that's what we're working on right now. So if anybody has any ideas about that, we tried devices. We use quite a few devices, and everything you said is true. They kind of become dust collectors for most people after a short period of time. And kids certainly aren't going to wear the devices. So I'm totally open to all your ideas.
John, before you respond, you said a word we haven't been saying that we were really remiss not to say, and I appreciate you doing that. It's one thing to talk about promoting people in the right direction. It's quite another to talk about sustaining. And there are many models for sustaining, but I've got one I'll tell you about later. Go ahead, John.
First of all, hi, Brian. The thing that's interesting is there was a study done by the Centers for Disease Control right here in San Diego about 15 years ago on the impact of chronic sustained stress in early childhood. What happens is you have sustained high levels of cortisol and high levels of the catecholamines, and it actually rewires your brain. So the connectome of a kid that's lived through prolonged severe stress is demonstrably different. Their fMRIs are demonstrably different. And so Matt mentioned a 40-year project of eliminating disease. I have a similar way of thinking about it, that it's a generational change, and that it begins with supporting parents and supporting young children to learn healthy habits of resiliency and how to respond to stress, because there's always going to be stress. There's always going to be an opportunity for sustained stress, and the most available tool that we have to deal with that is not the elimination of all stress, which is a noble goal, but how to teach children how to effectively recover and react to stress in positive ways. And I think that it's going to take generations to really promulgate that and systematize that, but I think it is a profound opportunity to contribute to that behavioral symphony of wellness, where we start off early. And if you look at prison populations, and you talk to folks who are in prison, I mean, almost every one of them can give you pretty good evidence of some pretty severe sustained stresses in early childhood. And so we're spending this immense amount of money on prisons that is very difficult to redirect to early childhood education, particularly in the behavioral field. But I think long-term investment in that is a very satisfying answer and approach.
So, John, you've every time you've answered a question, you've kind of directed it where I was thinking, which was this whole role of emotional health, not only in health, diet, exercise, and sleep driving emotional health, but emotional health then driving those three. So it's a big circle. And the whole plane of emotional health and what we're learning about it from a genetic point of view, physiological point of view, in terms of, inevitably we'll be able to affect people's behavior more constructively because we'll understand the physiological basis for it. But can all of you just sort of think about and comment about, because modern medicine doesn't do a very good job of dealing with emotional health. It treats disease, but not mental disease, just disease tissue. So, you know, that's something I think we all should sort of bring into our discussion.
It is an interesting market forces is that as the HMO movement began, 20 years ago, and as a result of the Nixon era wage and price freezes is where our modern healthcare system of fee-for-service came from, really. It became the employers who were accountable for paying the bill, and the employers were looking for a way to reduce their costs, and mental health was the first thing to go. It's shameful. I mean, what happens in this country with mental health is shameful, but it's very systematic, and it's not callous people. It's not people who don't care. It's that the social forces have been aligned with the employers controlling healthcare costs, and they've essentially carved out mental health services. And if you go to the NHS and look at how they deal with it, it's quite a bit different. So I think there's some systematic incentives that have led to that, and I agree with you wholeheartedly. I frame it a little bit differently in that it's mental health, it's psychological health, social health, and spiritual health. All three of those together are really prerequisite. And if any one of those is really lacking, it's very, very difficult to motivate anybody towards anything in a sustainable way.
So, we live in a generation where we now understand how all these factors impact our health. But it would seem that what we're trying to teach people to do is to be responsible about their own health. And yet, the previous generation, and maybe the current generation, is still in the mindset that bad health happens to them. That it would seem that we would want to develop sort of something that's like the equivalent of morality, but let's call it health responsibility. And we're doing that with young people, but how are we doing it with the whole population?
Let me give you a quick response, because that would take the rest of the evening to answer your question from everybody. It's just such a powerful question. Clint, do you want to say something first?
Yeah, I think so. I think so. Tie the gentleman's question in the back together and the emotional piece, which is that 2 or 3 years ago, we began to put together the idea of a dashboard. And there are inputs. There's going to be calories in, calories out that you can control. There's your sleep, your activity. That's the input. And the output's going to be blood pressure, weight, and glucose levels. So we have monitors that can help with all of this. So to your point, Martha, what can you change? What can you modify? We're not going to have radical behavior change. Yeah, exactly. Yeah, and if it's blood pressure you're looking at, how can you modify these? I think the one thing we missed was a happy face. Emotionally, how do you feel? Because if you're doing all these things and you're not feeling any better, then it's not working. So from that concept, I think that's where, for my role is in the standards world, I want these devices to be easily integrated so that app developers can come make these and not have to worry about the devices.
I'm going to change your response a bit. And when you're saying, how do we make people responsible or accountable? I would like to change it to, what can we do to encourage people to do the right thing? Isn't it important that we have information available to them that, for example, the reason when I drink that Diet Coke, I'm gaining weight is because the sugar receptors in my brain think I'm getting sugar and I'm not, and so I drink it and I want to keep eating more. There's a lot of kinds of things like that that people need to know so they can be successful in terms of what they eat, what they do, how they live, and so on and so forth. And give them at least that, where they can have a fair shot without even worrying about the responsibility question. I think comes prior to the responsibility issue. But I don't mean to diminish it. I'm just saying that may be a different way to look. I've got 2 people I cut off, so let me start here. 3.
Hi, this question is for the panel. Dr. Daniel Amen has 87,000 PET scans, brain images, if you will. And he's correlated a lot of information to ADD, anxiety, depression. Can you guys comment on that, how you guys are applying that information? And Matt, are you working with him? I hear UCLA and Scripps. So just curious on where you're going with that.
Yeah, interesting question. We're not working with him specifically, but we're working with a lot of other people who are doing very similar stuff. And Particularly at the moment, we're doing a very interesting study that's looking at correlating a lot of predictive factors. We'll look at correlating EEG, which is measuring brain activity, with psychometric profiling to look at how the brain works, if you like. Look at the connectivity, so the different parts of the brain that actually correlate and talk to each other, what sort of timing that happens. Look at genomic panels that help predict those things as well. Look at a phenotype assessment and anthropometry that looks to predict those things. We look at heart rate variability as well to help predict the state of the mind. So we're in stage 1 of that. Stage 2 is looking to work with depressive groups, and we're very interested in working out what ways can we initially predict someone's mood, someone's emotional status, depression, anxiety, etc., and then finding out what the right intervention is for them, specifically for them. And so it's interesting that a lot of the data out there that can predict with heart rate variability can tell you if you're happy or sad or depressed. A lot of other assessments can do similar sorts of things as well. And so we find, and again, this is just...
Mindfulness and biofeedback.
With mindfulness and biofeedback is a very large part too. And what it actually comes down to is that we're finding with all the research, it's actually very specific for each person. Someone may use a technique of meditation that will be very, very effective for them. For another person next to them, that may frustrate the hell out of them if they're sitting there trying to meditate. And I'm sure if we took a synopsis of the room here tonight, there'll be some people that can meditate and get great benefits, and others that sit there thinking, I'm looking at my watch, do I have to really do this? Is this really working? I feel like I'm asleep now. Lots of different things. So we look at, we're really trying to personalise what's right for everyone. We actually find phenomenal differences. People that can change foods. Some of the studies we do, we look at the brain activity and if someone actually eats an apple, what happens to their brain? If someone actually sits there and eats a banana, what happens to their brain? If someone goes for a walk around a track, what happens to their brain? How can that change their mood? There's some pretty cool biotech companies that are doing things. One called BioBeats, I'm not sure if anyone's familiar with those. That looks at matching heart rate to emotional status and actually playing your songs out of your iTunes library that can help change the frequency and again change your mood. We do a lot of work with sound frequencies, so lots of things. There's a lot of different interventions that exist out there, but it's choosing the right one for each person that's the real challenge. And again, we could talk to, everyone knows they should be eating healthy, everyone knows they should be getting some sleep, everyone knows they should be doing some exercise. That's not a new concept at all. I'm sure everyone in this room, their parents would have told that when they were born. We're still talking the same message and no one's listening. So how do we actually quantify that? We're trying to use a lot of the biometrics to help monitor that, to help collate a lot of that information so we can know what's happening in real time for the body and for the brain, and then actually trying to interpret that data and then provide a solution to each person, an individualised, personalised solution based on their expression of those genes at that point in time as to what's going to be right for them. So maybe your outcome would be some meditation, maybe it would be to eat certain foods at a different time of day and to avoid certain foods. Maybe it would be to change your social interactions and hang out with people that are more cruisy or more innovative and out there, rather than people who are too analytical and going down that track. So there's a lot of different answers, and we're really trying to quantify what's right for each person.
I'd like to come back to Martha's question because it's a question that I like to wrap my head around as much as possible. In how do we create sort of global systemic change in how people choose to live a healthy lifestyle. And I'm going to backtrack a little bit as a setup for my answer, but Richard Florida wrote a book, quite a few books, but one called Reset and the Creation of Creative Class, and the sort of the latest iteration of that is The Second Machine Age out of MIT. If you haven't read it yet, I highly recommend it. And the basic thesis is that AI and robotics are going to disintermediate about half of all current jobs around the world. The CEO of Blackstone, unrelated to this book, toured 40 countries in 4 months and found that every single president, premier of every country, he has the ability to speak to these people. He manages $3 trillion in assets. And every single one of them, their number one concern was structural job loss that's occurring from AI and robotics. And so everybody knows Google's bought 8 robotics companies. Many of you know that they have a big contract now with Foxconn, which makes all of our iPhones and all of our iPads, to basically unemploy all those people who are brought from the countryside to come work in the sweatshops at Foxconn. And this is happening all around the world. So what's that got to do with anything we're talking about tonight? If you follow the thesis of the Second Machine Age, The disintermediation of jobs is proceeding at an unprecedented pace that AI and robotics is fundamentally different than the invention of the wheel and the invention of agrarian lifestyle and the invention of urban lifestyle and the invention of the internet. It is fundamentally different, and it's moving at an accelerating pace, and that we are going to be looking at structural unemployment more and more and more rather than less. There will be new jobs created, there's no question, but the pace of change is going to be extraordinary. So given that there's going to be a rising social inequity structurally, if you follow that thesis, we have a major challenge on our hands because we don't have unlimited funds to answer Martha's question about how do we get everyone to understand why it's in their best interest to do certain things to maintain a healthy lifestyle. And so I think one of the things we need to do is really redefine, go back to the future a little bit, redefine what it is to be meaningfully employed, what a livable wage is, and then come back and focus on the children. We cannot possibly invest in everybody all the time, everywhere. And if we focus on those people who can afford the best interventions, we're only going to amplify the social inequities. And that may not concern everyone, but it concerns me deeply because I don't believe you have a stable opportunity for democracy and social health if you have essentially a very bipolar population in terms of access to resources. And so I think as we think about, how do we motivate different people to live healthy lifestyles, I really think we need to focus on all children and all parents who are supporting those children in a really big way, very urgently. And the other stuff that people can afford and that startups can monetize will happen because of market forces. We don't need to worry about that. But George Packer has written extensively in the New Yorker on the topic of democratization and the myth of democratization of technology. It does not raise all boats equally, and that social inequity is something we really need to deal with. So I didn't mean to turn this into a socialist pitch here, but I do believe that health is very much related to how people perceive their purpose, their value, their role in life. And I think that we're headed for some pretty serious times that need to be addressed very holistically and not just from the standpoint of how many steps you took yesterday.
Did that answer your question?
Hi, I'm Dan Wilkins. We've been hearing about some health issues across the board from all of you, but the common thread that I see is there's really a communication issue across the board. You keep talking about changing people's attitudes and educating people, and so there's this obviously a big gap between the knowledge that is here and the lack of knowledge that's out there in the world. I guess to what extent your good intentions are being outshouted by Taco Bell and the like. So I guess to what extent do the big, say, fast food providers, if people like that, have a responsibility to help in this cause?
So if you want to see a great discussion last night on Charlie Rose, the president of Ecuador, I guess you saw someone nodding their head, had a very eloquent articulation of the consequences of
letting market forces run your political system as opposed to having a political system that manages market forces. And in the construct of a behavioral symphony for wellness, you deserve a break today. I believe that you deserve a break from McDonald's today, and that's not going to come from Wall Street. And I think there are some fundamentals that need to be addressed. And I would say I don't believe education is the missing piece. Everybody knows what's healthy. What's missing is behavioral tools.
There's a wonderful book called Salt, Sugar, and Fat, written by a Pulitzer Prize winning columnist Michael Moss. I was with him a couple of weeks ago. Very impressive. It's certainly worth reading. It can help in terms of what the industry does to make us be hungrier and so on and so forth. Yeah, go ahead.
Hi, Phil Moylan from Viasat. A little bit more of a nuts and bolts type question. How do you see the adoption and growth of person-centric healthcare being affected by the need for patient privacy compliance?
Hey, Daniel.
It's a great question. It's one of the biggest challenges in information sharing that we have, especially as it relates to healthcare. You know, and it's somewhat demographic dependent. The younger you are, the more that you expect your information to be shared readily. The older you are, the more concerned you are about it. So we've got, we got a tremendous amount of education to deal with. The technology's there. We need more conformance to standards, and we're working this at a community level. You know, what we're doing at San Diego Health Connect is not trying to address national standards. We're convening our local providers up into considering a local patient identifier, which our nation won't do. But if we can agree to it at a local level, we can implement it here. So we're trying to deal with these things, keep in mind of national challenges and national policy issues. We're trying to do it at a local level. So all we can do is continue to push it to be convergent with national standards and to make it work in our community.
So Daniel and John, can we talk a little bit about open source data and personal health records and the fact of what we might be able to do as an interim thing to kind of get the ball rolling in the right direction? Go ahead, John.
So I want to respond to what Danny just said earlier in response to a question about privacy and sharing health data and the impact of personalized medicine. GINA, the genomics legislation to protect against discrimination, prevents discrimination against health insurance. It does not protect you against discrimination from any of these data for disability, life insurance, or long-term care. And those are monstrous gaps. And the reason it didn't is because the only way they could get that legislation through Congress was to nibble at the obvious, which was health insurance. But those other three are left. Until those other three are addressed at a policy level, people, frankly, have legitimate reason to be concerned. And so I am hoping that the zeitgeist in this country will change to where protection for those three other elements occurs, not just for genomics, but for every other piece of data. The other thing that I like to think about is that privacy is a relatively new construct. It's only been around for about 1,000 years. Back in the days of the tribal village, you know, there was night, and there were trees, and there were caves, and aside from that, there was no privacy. It's urbanization that has led to a lot of what we take as a God-given right of privacy. And it's interesting because there are both negative and positive consequences. And I like to think of, and David Brin, who's on the faculty here, wrote a brilliant book called Social Transparency in 1998, which is a benchmark in thinking in this space. But the way that I like to conceive of it is the flip side of privacy is reciprocal transparency. So we know the NSA knows more about us than we know about ourselves. We know that Malcolm can figure out more about our activity from his swarmology, liquid grids now is the new name, than we know about ourselves. And what I'm really interested in is having reciprocity and that transparency, so we know who has our data and what they're doing with it. And the Pew Research report that recently came out, and the Institute of Medicine found the same thing. People are much more interested in what you're doing with my data than who has my data. So in the post-Snowden era, I think there's some big opportunities towards more reciprocal transparency to sort of level the playing field. But I think we're back to the tribal era where, you know, if it's not dark and there isn't a tree nearby, it's pretty hard to maintain privacy.
Just quickly on that too, I guess when you're looking at bigger picture, you really want to consider the importance of your data and knowing about your person and what's happening right now. The questions that we're looking to answer is, and again, considering that a chronic disease will often occur as a symptom 10, 20, 30 years sometimes down the track. If you've got data now that you actually provide to a certain source, and then in 20 years' time you actually get sick, are you going to want to have someone to know about that data so they can actually help you get better? Or is that something you're happy to keep? Hey, I don't want anyone to have my data. So we're actually looking at the big picture where people are very concerned at the moment about, you know, de-identifying data. Does that exist? Does it not? At some stage down the future, you're going to want to actually know what your data is, because it's going to make a difference to your life and your health.
Before you respond, one of the tough things in Anglo-American jurisprudence is the balancing acts that we have. And I think, John, you raise a really profound issue in terms of the risk of data, and Matt, you in terms of the importance of having that data. So one of the real challenges is how do we come up with our initial conversation Daniel and I had is that so much is known about people. Shouldn't we be honest with people about letting them know what they need to know? Shouldn't we titrate transparency And I thought, what an arrogant thing to say. Who am I to titrate transparency? We should fully disclose. Well, the difference between full disclosure, there's got to be something in between. How do we deal with it? And that's where we started talking. Daniel, go ahead.
No, absolutely. Reciprocal transparency is a requirement of the healthcare information exchange, and we're working very hard to implement it. Again, it's another one of those challenges that has no easy, simple technological solution. But it is a requirement that we have to be able to report to the patient level what data is shared with who, when, and for what purposes. It's a huge audit log challenge, but it's fundamental to the healthcare information exchange.
One other thing I thought of, John, you were talking about the weight of the nation. David Hoffman is the person who put together the weight of the nation. And there's some encouraging things, because John, you depressed me a minute ago. The Institute of Medicine, actually the head of the Institute of Medicine, Harvey Feinberg, and David Hoffman, who did the weight of the nation, have just teamed up on a huge Institute of Medicine project to use media, which can get at most everybody, to be able to influence behaviors, to get people on the track, to understand what's going on. Even here in San Diego, there's an initiative that some of us have been involved with called the Be There campaign, to make San Diego the heart healthiest city in the United States, by using a campaign that Ralph Manierska and Greg Anton, who did Lance Armstrong's Tour of America, is using, called Be There, that has images you'll see on your TV of people fading out, grandpa fading out playing chess with the son, or you're there with your spouse at an event and fading out of the way, something that has an impact, that creates that mental image to make a difference. That may help at least for the beginning to your question, but it's not, it's just the beginning, tip of the iceberg. Yes, hold on, who else? Oh, I'm sorry, let's get one for the audience first, John. Who else do we have? Hold on. Who is next? Am I being, yes, Eric, and then you. And you're next, I'm sorry.
I just had
You'll be
a
next.
quick question actually from all of you on the panel, and more on the good news side is, I know I've read Dr. Dean Anderson has been lucky enough to work and do yoga with him a few times. And I think his best book was Reversing Heart Disease, and it was done in the 80s. And one of the good news is now Medicare covers his program. So
Absolutely.
I just would like to hear from the panel, and I know Clint with Qualcomm, you have a lot of good solutions that are working now. Apple I work with, and the iPad does some awesome things with autism. If we could hear some of the solutions that are here now, and Daniel, I know with platforms, the EMRs are opening up. Cerner, McKesson, I mean, that wasn't happening 2 years ago. So there's a lot of good news here to share, and I'd love to hear some of that. Thanks.
Yeah, we're at the point where solutions are coming to market very quickly, and they're using off-the-shelf phones that might get locked down for a specific purpose. There's our hub that's a special purpose hub as well, and there's more and more interest now in conducting these types of paying for these services. So we do expect the out-of-pocket market to occur, but in Europe, for example, they are putting up tenders for kits so that they can help monitor people remotely and keep them home. That's the big push right now. And these national hospital systems don't want to pay for people to be in the hospital. Denmark is cutting the number of hospitals that they're implementing. The other big phenomenon that's fascinating is that, and this is a problem, but it's a good problem, in these remote systems they want to add pedometers. But all these pedometers have proprietary protocols. So there's this chicken and egg right now where we're working, I'm not going to name any names because we're getting recorded, but we're working on the side of trying to get standardized pedometers in there because they now know activity is so important. So all of this is converging, and all the solutions are there. And actually, we had a call this morning about Bluetooth Low Energy, not to get too techie, but we're working really hard to make sure that those get lined up very quickly as well, so you can have plug-and-play sensors. So this is going to get in the standards body. So by the end of the year, it's going to be even easier to develop these kits.
As long as you raise Denmark, tell them what they're doing with their hospitals to make them more techy, to meet needs remotely, changing the whole system of their country.
Right, they're developing systems within hospitals so that they can manage patients outside as well. And they're absolutely remarkable. It's good that they're small enough to do this. It's a small country, and they're behind it, and they have good social medicine. But what we're doing, from my perspective, is I'm going to go there in 3 weeks, is to find the good systems there, and then we promote the heck out of it through Continua and others, so people can learn about it. All these countries want to try to do something, but there's just it's very difficult to find this information. So we're finding the best in class so that we can re-promote that all over the world.
Go ahead.
I'm getting back to the idea of media, and especially social media. There was a story a while back about a TV show called Teenage Mom, apparently having a positive effect on teenage pregnancies. So I'm wondering, can we leverage that through social media, Tumblr, Twitter, something like that, but start trying to get into people's heads, old and young, to respond the way they need to?
You actually raised an issue which we haven't talked enough about, and that is what's probably the biggest motivator for behavioral change are peers. And we really can, John, do you want to?
Okay, so if you haven't read the book called Connected, one of the two co-authors lives here in San Diego, James Fowler, is on the faculty at UCSD, and the other one's Nicholas Christakis at Harvard. They wrote the book when they were at Harvard. And they both continue to publish an amazing literature on the opportunity of social for health and the influence of social on health. And so they looked at the Framingham data from pre-Friendster, pre-Facebook, and showed that if you move from a culture where people are not taking care of themselves, you will be overweight like them. And if you relocate to a community where people are really active and exercising, you will lose weight just by changing your social environment. And so we're doing some work with James Fowler right now. He just published another amazing paper last week in PLOS ONE on the ability of Twitter to detect global contagious outbreaks. But we're doing work to do exactly what you're describing. We are validating 7 biomarkers in volunteers who authorize us to take their Facebook feed, compare it with their electronic health record, and help understand early indicators that can be statistically validated, and then use that information to do broadcast messages out to the social network, unbranded. But the point is that your social network has such a powerful influence. Our goal is not to improve the health exclusively of our Kaiser members. Our goal is to include the health of the entire community as we are able to discover it through authorization of participants in looking at social and validated biomarkers. So this is a very, very active, rich area that is also entrapped in the whole privacy debate.
I just wanted to make one quick point also about, we always look at the carrot and the stick and how do we motivate people and make them feel better. Then there's the stick. My hero is Mayor Bloomberg, who went in and he outlawed trans fats. He was that far from sugar. He outlawed smoking. I want him to come speak at the M-Health Summit, this big event coming up soon. And I think something that kind of went under the radar is that child obesity went down last year. Much of it was because Mrs. Obama got healthier food into schools. So from a policy perspective, when can we actually get brave and start making these decisions? Like the high fructose corn syrup. I just learned about this in sodas not long ago. It used to be when there was pure sugar in there, you got one and you were full. Now with the high fructose corn syrup, you want to keep drinking. So there's all of this I call it the man, the food company, that's making us think that this is healthy, and it's not. There's so many structural and policy things I think we can do, and we never talk about that.
Clint, you raised such an important point too that we haven't focused on either. I can't do everything, but obviously the health does not happen in your doctor's office, sports fans. It just doesn't happen there. Physicians are not trained in behavioral economics. They're not trained in exercise physiology. They're not trained in mindfulness. They know very little about nutrition. And in fact, they're about sickness, so they're probably not just the best place to go, but the worst place to go, for starters. And there's all these other elements, and that's our peers, Facebook, robust data, all kinds of other things that should be making a difference. We need to move out of the sickness model to a model that thinks differently. It has been keeping us in a box. Go ahead, anyone.
Glad you didn't have a microphone then, Dennis. That was very powerful. So I guess just to touch on the social media, we're actually doing a lot of work internationally at the moment to, which is what I find interesting, to get a viral video campaigns up and running. How do you...
Excuse me, we know we're running over. Those of you that have to go. We're going to stay about another 7 minutes. Thank you.
To answer the questions as to what's a viral video is interesting in itself, but it's a very, very interesting topic, and we have a lot of education awareness to come as we talk about a lot of things tonight. Thanks, John, for coming, mate. It's been an interesting campaign that we're looking at. We're looking at also, from the guys up the back, the gamification is a very interesting part. We're doing a lot of the research on the brain at the moment to look at what people respond differently to what things. Some people respond differently to neurocognitive tasks and engaging with online components, others to mobile phones, others to actual video games. And so the gamification itself isn't even an easy answer. There's a lot of different gamifications aspects that people have.
But I think the point of gamification is that we can make what otherwise it seems overwhelming fun. And that's, we can't forget that either. Go ahead, please.
I was going to say that I feel a lot of the lifestyle changes comes from media and from TV. And we can call it healthy or not healthy, but I think there needs to be a focus on partnership with the large media players or with the fast food players. Because I think healthy lifestyle only comes once you begin to make the assessment as to what is healthy and what is not healthy. But the first focus always seems to be, what is the trend? What are my friends using? What am I being bombarded with TV? And that's the choice rather than healthy or not. And it's not until long after you're either addicted to a product or the impact has happened that you realize the consequence or the definition of healthy. But I think you need to get the young people and the families where they're influenced the most, and that's through media. And I'm wondering if anybody's doing that.
I mentioned the effort with Institute of Medicine. That's going to be a big one. Go ahead, Glenn. Did you want to add something you said earlier about foods?
Yeah. What I want to say that what I get upset with media is that they sometimes follow the trends, and when they do that, they have obese children on these shows that are comedians, and so kids think that's okay. And when are they going to have the strength to do that? But on the other hand, wasn't it some anorexic model recently? Was it a Abercrombie and Finch model? At least there was an outroar about that she was too skinny. So we have to find some fine line in between there. There's no doubt.
It's interesting though, Clint, I want to just address something we were talking about earlier and tie in privacy. So I was talking to Ronnie Ziegler recently, and he was talking about differential privacy. If there's something in it for me, I don't care. If there's something in it for me, I don't care how you got to me. When you think about the trickle-down effect that your devices and wearables and sensors and all that, it will happen. We actually have the tools to address a couple of the issues that we've been discussing tonight. The kids of this country are in the social networks. You're going to create an explosion of data amongst them by getting that trickle down. We actually have some fundamental tools that are available to us. A lack of concern about privacy. What's in it for me works very well. You've got lots of data being shared amongst peers that actually want to affect each other in the partnership the lady just discussed.
Yeah, you're absolutely right. That's going to happen.
Two more questions.
We have a wonderful experiment going on between Europe and the United States. If we had the average of a Western European country in terms of cost and health status, many of the problems in the United States would be gone. Our budget deficits currently and forecasted into the future, and we'd have better health status. And I just think it's an interesting question as to what drives us to think that technology is going to be the answer. In Europe, it's not like they're all connected and they have all this data and we don't. Is it because we don't think our system can ever change enough to have that system serve us? See, I would disagree with your comment about doctors. I don't think that's how people in Europe feel about their doctors. I lived in Europe and actually found them a very important part of how we solve and improve people's health status. So I just think it's an interesting question of why we always turn to technology as our answer.
Well, I think that right now Europe is going the fastest as far as developing remote monitoring systems because they want to save money. The rich countries, the Scandinavians, I was with the Catalan health ministry and they didn't have enough. They want to do remote monitoring, but they don't have the money, so they wanted us all to come in and do partnerships. So from that perspective, they're embracing it, and they don't always have money, and that's a huge problem. That's why Denmark, we're going there to Scandinavia to really pull the best case studies out of there, and they're not afraid of technology. They're embracing keeping people at home with technology.
Just a disclaimer, I'm not a physician leader. I'm on the board of the American Academy of Family Physicians, and I'm the head of the White House task force dealing with this stuff with physicians. The physicians that I work with that are thought leaders in this area realize that the new role of the physician is becoming that more of a chief executive officer that has these other people working with them to meet the need because they do not have the knowledge base, and it's unfair to ask it of them. So it's not that they don't care. As persons they may know it, but as physicians they don't. Matt?
This is a very, very general point, but the way that medicine's practiced in Europe, as you know if you've lived there, is a little bit different to how it is over here too. And they're actually required to do follow-up with clients. They're required to be there for their clients or their patients or the person all the time. We work with a lot of doctors over there that outside of ours will send emails, will make phone calls, will regularly talk to their people because they're responsible for them to be healthy. That's different here in the US and also in Australia to somewhat, where it's if you come to see me, I get paid for the session and that's it, thanks. If you want to see me and talk again, then come back and make another appointment. So it's a little bit of a different, generalistic philosophy that exists there, which I think underpins a lot of what we're talking about, trying to change the medical system, the educational system. It is a little bit different over there. The cultures do make a difference in the different countries.
I was amazed when I worked with the Soviet government years ago that the low tech was amazing. The care that was provided was bizarre. It was so much better than ours. High tech wasn't so good, but it's a different philosophy. I think we're done. Thank you all so much.